Welcome to The Art of Medicine, the program that explores the arts, business, and clinical aspects of the practice of medicine. I'm your host, Dr. Andrew Wilner, and today we're going to talk about a topic that I think doesn't get enough play. It's in the back of the mind of many healthcare providers, but we don't talk about it too much, and when we do talk about it, we're not too happy about it. So I thought I'd bring an expert on, Dr. David Feldman. But before we get started, a word from our sponsor, locumstory.com. If you're considering locum tenens, either full time or on the side, you probably have a question or two, or 20. Fortunately, locumstory.com has the answers you need. It's packed with unbiased information and advice from physicians. Locumstory.com has nothing to sell. It's simply an information resource. You'll find super handy tools that let you see locum tenens trends for your specialty and compare different locums agencies. There's even a quiz to help you decide if locums is right for you. Locumstory.com is the perfect place to start if you want to learn more about locums. That's locumstory.com. And now, without further ado, I'd like to welcome our guest, Dr. David Feldman. Welcome.
Thanks so much for having me, Andrew. Appreciate being here.
So, you asked me earlier when we were chatting, how did I find you? And I saw you on a one of these things, and I said, that's the guy I gotta get because your story is, well, you'll agree, it's a little unusual, right?
Yeah,
So tell us, medical school residency, what you were doing, and how you ended up in that seat.
sure. It's kind of funny when people ask me to describe myself. I say, well, I'm kind of an alternative career doc. I don't know, maybe that's the best way to describe it. I think if somebody had asked me, and this is probably true for most people, not just physicians, if somebody had asked me when I was finishing college or med school if I'd ever be the chief medical officer for a national malpractice insurance company, I would have said, what? Why would I be doing that? I actually come from a family of dentists and was exposed to healthcare early on and knew I wanted to be in a healthcare profession, but felt I wanted to be a little more broadly based than dentistry. And my father and grandfather didn't hold it against me. My brother went to dental school, so they'd got somebody. But I did find that I had interests that well extended beyond just academics. And as I went through medical school, beyond healthcare, a lot around leadership and management. And even as a surgical resident, and as a plastic surgery resident, I'm a plastic surgeon by background. I took some leadership opportunities in the OR committee, doing some analyses as a plastic surgery resident. And then when I went into practice, I went into practice full time at a great hospital in Brooklyn, New York, Maimonides Medical Center, where I spent 20 years. And I tell people it was sort of like a lab for me. And much of that is due to the forward thinking nature of the CEO at the time, who was really very good about encouraging me as a physician to explore things that were a little different for a physician to do. I started out as a director of plastic surgery and building my own practice and understanding how to the art and science of practicing medicine, which I loved. But also along the way, I got involved in medical staff politics, became the medical staff president, and then somewhere about 10 years in, the hospital asked me to be a part-time OR administrator. I'm not sure why. I guess partly they were having some difficulties with OR leadership and they wanted to get physicians involved. Typically, ORs are run by nurses, but I think they realized having physicians involved would probably be helpful. I think that's a good idea. And they sort of assigned me on to the business side and had another surgeon be on the clinical side. So I was looking at supplies and all these other things. I guess they figured as a plastic surgeon, I knew about drains and sutures and that kind of thing. But the first thing I told them was, you need to hire a full-time OR business manager. I was doing this one day a week, and this is a big operating room with a big supply budget, total joint replacements, and so forth. But I learned a lot about management and decided at that point that my future was not going to be in practice. And I went to business school, did an executive program at NYU, and really was just profoundly impressed by all the other aspects of business and the business of medicine. And I think it's an important tool to have. I don't think it's necessary that every physician interested in the business side of medicine go to business school, but understanding how the business side works is so helpful because the reverse is nearly impossible. I just don't think it's easy for a business person to understand what it's like to take care of a patient unless you actually do take care of a patient. So we are in a unique position to do that. And many of the things that physicians complain about, frankly, I think are due to our inability to take care of themselves, take care of them ourselves. So some of us, and I'm one of them, need to get involved in these things so that physicians and healthcare people writ large can get involved in making the changes we need to make healthcare as good as it can be, knowing that it's not isolated, it's in the milieu of everything else in society. So I did this, went to business school, and when I finished, I transitioned from 80% practice, 20% administration to the reverse. I actually ran the operating rooms. I was the vice president for perioperative services, and I felt it was important to do it as a team. And I still think it's a best practice in OR management to have a triumvirate or a quadumvirate of a nurse, surgeon, anesthesiologist, and administrator. I served the role of a surgeon administrator because I was also part of the senior healthcare team. And the three of us really worked so well together for about 7 or 8 years. And I like to say that working in and directing an operating room, I really stared patient safety in the face, literally, and became passionate about patient safety. I became passionate about how healthcares treat each other and treat their patients, especially surgeons. And I wrote a code of mutual respect because I really believe, and I still believe to this day, that anything we do to improve healthcare and patient safety is going to require people being respectful of one another. And then towards the end of my time there, I became the patient safety officer, another role that was sort of unusual for a physician and certainly a surgeon. And then about 11 years ago, I got asked to be the chief medical officer at a malpractice insurance company. And I suppose if somebody had asked me at the time what my next job would be, I would have said, well, probably a patient safety officer for a system. And that's kind of what I am. The system is not what you think of as a healthcare system. It's a group of hospitals that share their malpractice company. But that's really what I've been doing for the last 11 years, is working with physicians, nurses, other healthcare folks on how to prevent malpractice. And I can go into a little detail about how we think about that. But I consider myself a patient safety guy, if you will. And that's really where I am now. And my hope is that because I don't practice anymore. I had to throw out my OR shoes about 11 years ago. But I am hoping that I'm impacting, obviously, lots of patients all at once. And every couple of days I see evidence of that. And that's what helps me sleep at night. So that's where I am today.
Well, that's a great story. I listened to John Jerica's podcast, and I've been on it a couple times, and he talks about physicians transitioning to non-clinical careers. And I think yours is a great story because you just followed your passion. You know, you're practicing, everything's great. Plastic surgeons do well. You didn't leave because you weren't making enough money, right? That wasn't the problem. But you got very interested in sort of, well, we can do this better from an organizational standpoint. And then, patient safety, I'm sure you saw things that you said, whoa, that didn't have to happen, right? We can make sure that that doesn't happen, and patients do better, and doctors, do better, and everyone does better. So now I think you said 11 years, you've been in the malpractice business. So what is your role exactly now?
So what happened was when I first started 11 years ago, I became the chief medical officer for a company that managed the self-insurance program for multiple big academic institutions in New York and the New York City area, including Maimonides, where I came from. And that's part of that is not unusual. Most big academic medical centers around the country don't buy insurance. They are self-insured. And there's two reasons for that. One, it's very expensive. You can imagine, especially in a place like New York City, how expensive it is to have malpractice. And hospitals that are big enough, systems can manage the variability year by year when things go up and down. And then most of their physicians, especially now, are full-time employees, and they have control over it that way because they control the program. So we manage the program for them, and that includes claims, and it's the other side of the company, and what I do in risk management, prevention of claims for these hospitals. About 3 years ago, our company, the hospitals, decided to sell us. They didn't want to be in the insurance business. We still manage their program, but we're now owned by the Doctors Company Group, which is the largest physician-owned malpractice company in the United States. We insure almost 100,000 physicians across the country. And the company started really in California. It's now nationwide. And we insure really about half of our clients, our physician insureds, are in groups of 1 to 5, in small groups. And I think most of us know that that model of healthcare delivery is changing. If you talk to folks that are finishing their training now, I have a son-in-law who's a third-year resident at one of our hospitals in New York City. He's not going to go into solo practice. He's going to join a big group or join a hospital staff, and that's what most residents are doing now. I think the doctor's company realized the future they needed to have the ability to do the things that a company in New York that we do, which is managing self-insurance programs, big groups, hospitals, that kind of thing. So we became a part of the doctor's company group. HRA were called Healthcare Risk Advisors in New York. We're part of the Doctors Company Group. I maintain my role as a CMO for Healthcare Risk Advisors in New York, but I'm also the Chief Medical Officer for the national company. So now I have an opportunity to work in patient safety and risk management across the board, from doctors in small practices, big practices, small hospitals, big hospitals, all very different, very different. We can talk a little bit about the differences in that and how we impact safety and risk management in different venues. But it's both challenging and rewarding. I haven't looked back. It's really been great.
Well, every doctor wants a good outcome for their
Yep.
patient. And on the other hand, and of course, the legal system with the possibility of a malpractice suit is designed to help patients who, were not treated properly and compensate them and help them if there is a problem. And yet, that system is adversarial. So it kind of gets in the way of the physician patient alliance, which is what I teach my residents about. You want to bond with the patient. But it's
Right.
very hard to bond with the patient when you think that that patient is going to sue you.
Yeah.
So,
No.
do doctors think about malpractice too much or not enough?
Well, I think that depends on the doctor. I think a lot of doctors think about it. It also depends on where they practice. The one thing I will say for your audience that's crucial to remember in the world of malpractice, like a lot of things in this country, is state-based. And the malpractice milieu, if that's the right term, in a state like New York is completely different, believe it or not, than a state like New Jersey. And I work in New York and live in New Jersey. They're just different. And if you go to Pennsylvania, it's different yet again. Every state has their little nuances to how the system works. So depending on where you are, malpractice can either be in your face as a physician, or you don't really hear or see about it much at all. And of course, a lot of it depends on the specialty you're in. I like to say that malpractice is not risk adjusted, even though most of us in healthcare and certainly physicians feel like when we're looking at outcomes, and we should be looking at outcomes, we want to take into account the fact that certain patients are more likely to have complications than others. It doesn't mean they all will, but they're more likely to. So we should think about that as we start analyzing outcomes. That doesn't happen in malpractice. It's really a bit of a numbers game. Um, and when there's an adverse event, a bad outcome, whether it was expected or not, a patient can bring a lawsuit, and the things that the patients can see make it more likely for them to do that. So surgery is pretty much on the top. Well, surgery writ large, all kinds of surgery, is usually on the top of the list of the most common kinds of malpractice. And then you've got the most common specialties, if you will. OB is the thing that people think of all the time. Turns out it's the volume of OB malpractice claimed may not be so high, but the dollar amounts associated with them are particularly high, especially in places like New York, because we're talking here about damaged babies, neurologically impaired children who have a lifetime of help and health care that they're going to need, and that's very expensive. As opposed to, say, a nursing claim that usually involves care of a patient where there's been a fall or a pressure sore. Those tend to be in patients on the other end of the age spectrum, right? So it's a very different kind of claim. Departments in medicine like yours in neurology are in there, but a lot of this is also dependent on what the plaintiff's bar is thinking about. They're not going to take claims on they don't think they can win, because in most of the United States, all the United States, plaintiff's attorney work on a contingency basis. They don't get paid unless they win. So they're not likely to take on a claim they think they can't win or is not worth very much. Sounds sort of ridiculous to talk about worth when we're in healthcare, but that's the way the malpractice system works. So I think it depends on the doctor, their practice, where they practice, what kind of medicine they practice. as to whether it really is something that's, they really think about all the time or not.
All right. Well, I think, so what can physicians well, I was going to say, for surgeons, it's more clear. There's more clear cause and effect. The patient was fine, they go into surgery, and then they died. Well, the surgeon
Right,
has something to do with it, or the anesthesiologist, or something
right.
bad happened. But, you go to the psychiatrist and you come out, it's like, well, how do you know what he really did or didn't
Yeah.
do, or should he have done? So it's a little more difficult to kind of pin it on him. So I suspect that has a lot to do with it. It's not
Yeah.
that surgeons are more likely to make errors than any other
No,
specialty.
correct. That
All
is
right.
correct.
It's
I
just
said,
their errors are.
see it. It's very visible. I'm a plastic surgeon. Typically, if there's something that went wrong, it is really visible, right? So, as opposed to a doctor that's prescribing medicines or a behavioral healthcare specialist, right, where it's not so clear what the doctor's role in is in whatever outcome there is. So we tend to think, Andrew, the way I think about malpractice risk reduction, and I think this can be helpful for your listeners that are interested in figuring out what they can do to keep themselves away from malpractice. We have a model that our claims director and I came up with a number of years ago as part of teaching a class to some medical students. We call the 3P model, the 3Ps of malpractice risk reduction. So the first P, and the easiest way to think about keeping you away from malpractice is to prevent adverse events, right? If nothing goes wrong, it's not going to be any lawsuits, pretty much. Easy for me to say. Most of the time when I'm talking to clinicians and I say that, they kind of smile and say, you're out of your mind because we can't prevent all adverse events. And they're not wrong. In 2022, maybe half of the things that we don't want to happen can we prevent. And we're getting better at some of these things. But we can't prevent all of them. But the fact is, my favorite oxymoron in malpractice is the good news about malpractice, using those two words in the same sentence, a little weird, is there's not a lot of it. Even in a place like New York City, where I'm based, where the laws are such that there tends to be more malpractice claims than a lot of other places and they're more expensive, it's still not that common, even in the face of an adverse event. Think about obstetrics again. A lot of people think about that as a high risk specialty. And in New York, where the rates are probably twice as high as everywhere else, there may be one malpractice claim for every 1,000 deliveries, which doesn't sound like a lot when you think about how many times things can go wrong during a delivery. And we're talking about a range of things from fairly simple, reversible things that don't impact the life of mom or baby, all the way up to devastating things we've mentioned before. And there's an order of magnitude difference. It's not one, it's probably 50, 60, 70 out of 1,000, one lawsuit. And that's true in other specialties. Why is it that there's that one lawsuit? And most of the time there isn't. The second P, precluding malpractice cases in the face of an adverse event, is really about communication. I think most of us believe, you and I have talked about this, the relationship we have with patients. And the term that I really don't like is disclosure. People throw that term a lot around, around a lot. And I think the problem, it implies a one-shot conversation after something happens. I had a mentor when I was a plastic surgery resident said, if you talk to patients about potential complications before surgery, it's informed consent. If you talk to them about it after surgery, it's an excuse, right? So there has to be this continuum of conversation before, during, and after whatever interaction a patient has with us as healthcare providers. That is so critical in keeping yourself away from a malpractice case in the face of an adverse event. And then finally, the third P relates to the fact that some events are really so devastating for patients. And then there are nuances to who the patient is and who they know that you can't preclude that malpractice case. The neurologically impaired child we were referring to, someone goes to have a total joint replacement, a hip replacement, ends up with a foot drop. I mean, that's a pretty devastating event to have. And there, the third P is how do you prevail in a malpractice case when you can't preclude it? And there, I think most of us know it's about documentation. Most of these claims happen years after the event, and there's probably been thousands of encounters that we as physicians have had in the interim. How can you possibly remember what you did or said? Or more importantly, defending yourself. If you go to the chart and it's very clear what you were thinking, good medical judgment is tough to sue against because doctors are allowed to have that if you can demonstrate what they were thinking. And if you write in your chart or type in your chart what you were thinking, why you decided to do one thing, why you didn't decide to do something else. It's much easier for our defense attorneys to defend a physician when they can show those, this is what the doctor was thinking and why he did or she did what they did. So those are the three P's. So everything we do in malpractice risk reduction has to do with one of those things: helping to prevent adverse events, improving communication, improving documentation.
I want to thank you for that because I think we can take that home and might be helpful. And I want to focus on that last piece because I talk to my residents about this, and sometimes I feel like I'm kind of an outlier. In my note, I like to explain, we need an EEG because we want to rule out status, or we don't need an EEG because status is unlikely. But I like to put a little, and I tell them, some context. Whereas most of the notes I see from all of the other subspecialties are basically, bullet points. MRI, EEG, LP, return to clinic at 6 months with no sort of window into what the thinking is.
Yeah.
That is the standard that I see. Now, so who's right? Am I right? Or, it takes more time, obviously, to explain yourself and discuss it. Or is everybody else doing it wrong?
Well, look, like everything else, there's no one size fits all, right? And most doctors listening to would say, oh, that's great. If I'm going to do that on every patient, I forget pajama time. I'll never be able to get to sleep at night. I'll be spending my entire night writing in charts, right? So there's got to be some kind of healthy balance. And that, again, is something that physicians have to figure out what the right balance is. I would say this, my legal colleagues like to tell me that most of the time what you write in the chart, nobody ever sees, except maybe the billing people, right? Think about it. Only when there's a lawsuit do people look at it, and believe me, they dissect every word. They blow it up on a screen behind you in a courtroom if that's the case, right? And then they're going to look at every little thing. So it's not to say that you shouldn't document that way on most of your patients, but pick and choose. Look, some things are pretty straightforward in healthcare, right? And maybe for those you don't need a lot of explanation. But certainly with a difficult or complicated patient, or somebody who you have a sense is troubled, or there's things that are going wrong, those cases you probably do want to document a little bit more, thinking that if there is a lawsuit, it's pretty obvious why I did what I did. Also, I think some of this, look, the charts, I mean, I'm of an age that you are, not to say that, Andrew,
Thank you.
but right, where actually you had consultants and doctors would read each other's notes, right? I mean, I'm assuming they do that now. So some of this is not just what you write in the chart if there's a lawsuit, but let's be honest, the chart was there, really, it was created so the people taking care of the patient can see what everybody else is saying, reading the nurse's notes, right? Therapist notes, all that is part of taking care of the patient. And it's supposed to tell a story that you, as a participating member of that team, can read and understand, and supplemented by, we hope, conversations with those people too. That's always nice also, right? So I think it's like everything else. There's probably no one right answer, but use your judgment. It's the old, like I remember the old days when I was working in an ER, somebody, if you think you should admit that patient, just admit them, right? If you think you probably should write a little bit more in that note, write a little bit more.
I like that. I want to ask a very specific question also. This podcast originated from my work in locum tenens.
Mm-hmm.
So it occurred to me that as a locum tenens physician, where you go to multiple sites, right? You work in one hospital for a few months, another hospital for a few months. You don't know anybody. You don't know where anything is. You don't know the system. You may not be that fluent with the EMR. Is there an increased risk for locum tenens physicians to be, to commit malpractice and for that to be recognized? Now, I'll just say that when I looked into this, I couldn't find any data that said that was true. It seemed like it might be true, but you have a lot more experience with this than me. So tell
Yeah.
us.
So I'm going to be a little tricky here, Andrew, and turn this around a little bit. And what I would ask you, because remember what I said about the three Ps, right? So let's go to that first P. Do you think that physicians working in a locum tenens situations are more likely to have adverse outcomes?
Not because of the quality of their work.
For whatever reason. Remember, this is not risk
Maybe
adjusted.
systemic reasons, though, right? Sometimes the system sets you up for failure. So I think that, for the reasons I suggested, you order something, but you ordered it the wrong way, so it never really happens, stuff like that.
is patient safety 101, right? A lot of this is about the system, not the people, right? So you think about it, and doctors often don't like the airline analogy, but the team on the Miracle on the Hudson had never worked with each other before. But they were in a system where they knew what their roles were, right? So it was easy for them to work with each other. When I ran the ORs, I used to have surgeons telling me all the time, listen, I will get the best outcomes if you have the same people working with me all the time. And they may not be wrong, except for one thing, they're people. And sometimes they're on vacation and sometimes they get sick. And then if nobody else knows what you do, this is going to be a disaster. You can't run things like, not a complex place like an operating room, right? So you need to have systems in place so everybody knows how to do the right thing. And we really are not very good at that in healthcare. So that when you have somebody who's working in a locum tenens situation, they're by definition in a place they may never have worked before, with people they never worked before. They have no relationships with people. They don't have long-standing relationships with patients, and that depends on the role they're taking, what kind of physician they are. ED docs never have a relationship with their patient. They really have a much tougher time developing that relationship. So for all those reasons, first of all, a lot of underwriters, the people who decide whether they'll even write a malpractice policy for locum tenens, are not very keen about writing a doctor that's all they do. There are some companies that do lots of things and they're creating their own locum tenens organization to deal with helping people outside of their region, if you will. Those are a little easier to understand. But in the world, malpractice is still insurance, and you've got actuaries and people are looking at history and they're trying to figure out what's the risk we're taking that this physician is going to be involved in a claim. And it's just, for all the reasons we talked about, it just makes it seem more risky. Does it have to be that way? I don't think so, but that means we got to make a better system.
So locum tenens physicians should probably focus more on the last two P's, right? Of communicating more with their patients to try and smooth
Sure.
that part. Remind me what the third P was?
Third P is prevail in a lawsuit. That's documentation.
Oh, and
That's what you
documentation.
do in any situation, right? So, yeah, absolutely. Well, listen, we should all of us as clinicians ought to be cognizant of our outcomes. Some of that's easy to measure, some of it is not. We're getting some better at that as the data gets better, but we should be, because that's the first thing you can do to keep yourself away from lawsuits, is make sure your outcomes are as good as they can be. But we know we can't prevent them all. That second P, you're right. If you're in a kind of situation as a primary care physician, family medicine doc, OBGYN, and you can develop a relationship with your patient, regardless of whether you're locum tenens or not, you're much less likely to be sued if there's an adverse outcome. It's just, I believe that. I really do. And there's data to show that, interesting data to show the reverse, that doctors who have more, and this data comes from Vanderbilt in your state, on unsolicited patient complaints. This is 20 years old, this literature. Unsolicited patient complaints are predictive of malpractice. And it wouldn't surprise anybody, right? And now they've shown that unsolicited complaints from coworkers also predicts lawsuits. And it predicts worse outcomes for surgeons. And some of that's intuitive, but there's data to show it really is. It's not soft science.
All right, I'm going to start bringing cookies to work. And Dr. Feldman, this has been a
Whatever
great
helps.
discussion. That's right. And I definitely picked the right guy. Is there anything else you'd like to add before we wrap up?
Well, I guess I would be remiss if I didn't reflect a little bit on the state of medicine in the last few years. One of the things I've really come to realize is that most healthcare now is still delivered outside hospitals, and the world I'm in, not even just malpractice and patient safety and risk management, is very hospital focused because there's resources to do that. You ask, a typical doctor practice, who's your risk manager? And they're like, risk manager? We have an office administrator, and they kind of do everything. But most healthcare is still delivered in those settings, and more of it is now. People are talking about hospitals from home, right? And telehealth has allowed us to treat patients from remote areas, which I think is very patient centric. I think it's great under the right circumstances. How do we make sure that the care we're delivering outside of major institutions where some of these resources and the focus is there, how do we make sure we're delivering high quality care and high degrees of safety and quality in those arenas? And I would only offer one suggestion that comes from one of our strategic business units at the doctor's company, Medical Advantage. They've been very experienced in the value-based care model in something called a high-touch practice. And it addresses all three Ps. Practice in a high-touch practice, that means reaching out to your patients all the time with their lab results, right? So you're not likely to miss something and have an adverse event. And you're constantly talking to them. That's that relationship, so that if there is an event, you're less likely to be sued. Second P. And then all this stuff goes in the chart, because that's the way you get paid in value-based care, and it's a good thing to do anyway. So you have a way to defend yourself. High touch care, I think, is really a nice mantra for practices that is good medicine and hopefully reduces your risk at the same time.
Well, Dr. Feldman, I know you have many more pearls to share. So if someone wants to get in touch with you, how can they do that?
I'd be delighted to chat with anybody. My email address is dfeldman@tdchra.com. I think you're going to put that on the screen, which is fine with me. Please reach out, email. Be happy to have a conversation with you about any of these things. Look forward to hearing from any of you.
Dr. Feldman, I want to thank you very much for appearing on The Art of Medicine.
Thank you, Andrew. Really a pleasure to be here and to chat with you.
Finally, many thanks to The Art of Medicine's wonderful sponsor, locumstory.com. If you're interested in learning more about locum tenens or considering a new full-time position, please go to locumstory.com. I'm your host, Dr. Andrew Wilner. Thanks for joining the program, and what a wonderful guest. See you next time. This program is hosted, edited, and produced by Andrew Wilner, MD, FACP, FAAN. Guests receive no financial compensation for their appearance on The Art of Medicine. Andrew Wilner, MD, is Associate Professor of Neurology at the University of Tennessee Health Science Center, Memphis, Tennessee. Views, thoughts, and opinions expressed on this program belong solely to Dr. Wilner and his guests, and not necessarily to their employers, organizations, or other group or individual. While this program intends to be informative, it is meant for entertainment purposes only. The Art of Medicine does not offer professional financial, legal, or medical advice. Dr. Wilner and his guests assume no responsibility or liability for any damages, financial or otherwise, that arise in connection with consuming this program's content. Thanks for watching. For more episodes of The Art of Medicine, please subscribe. www.andrewwilner.com